So, can I go to table number 6, table number 9, and table number 14? Folks, can we get you all back, please? Okay, table number 6. Sorry, everybody at the back, can we ask you all to sit down, please, and just get a bit of quiet? Okay, table number 6, please. A bit of quiet and respect, please, for table. Okay, number 6.
Thank you for your presentation. Really, really interesting facts there. I'd just like to ask Dr. Sean Foy, in your model of biophysio and social issues, have you any advice for us as part of this assembly as to how we could integrate your model into a solution-driven method of reducing addiction in our society? Thank you.
Thank you. I'm going to table number. We're going to take a few together. Table number 9. Did I say 9? Yeah, I did. Table number 9.
Hi. Good afternoon. The question we just had was in relation to codeine. I suppose the last presenter could also answer that. It was with regards to poison with paracetamol and codeine involved. But sometimes we didn't really see if there was any data that was captured with the paracetamol and codeine, or was it just, non-over-the-counter prescribed medications? I don't know if I made that clear.
Thank you. Table number 14.
Oh, sorry.
Did I say 14?
Yes, you did. Yes. Are people who experience trauma prescribed medication too easily? And not all people who experience trauma use medication. Could we learn from them?
Thank you. So I think the latter two questions probably initially for Ida, if I can, which was the cocaine clarification on the issue of trauma and medication, and then Sean for the first question, if that's okay, and then we can open it out as well.
Yeah. So thanks for the question. So the interesting thing about the biopsychosocial model is that, look, it's nothing new. We've known about addiction for a very long time, and as Ida kind of pointed out, it is really the way to work with people. So it does exist. I think what we need to do is strengthen and underpin its existence, and some of this will be with having more services trained in doing it. What can often happen is that there is a lead, especially when there's substance misuse issue that leads to dependence. What can happen is that it can become very medicalised. So we try and replace the drug that somebody has taken, say with heroin, it might be methadone or Subutex. But with other drugs that people are using, we don't actually have a medical replacement. So the biopsychosocial model is actually the way to go. So to answer the question, what I think is that it does exist. People are doing it. But I think we should really have a much more coordinated response to it, and that it would be a level playing field, so not necessarily led by medics. So that's my answer.
Interesting. Thanks. Ida, do you want to take the two other questions? That's okay?
Yeah. Well, I think your point maybe was in terms of overdose and death in relation to codeine, and codeine would come in under the opioid statistics. But I suppose my point really was around the use of and the misuse of codeine, which is legally available over the counter, and people who get dependent on the likes of, Solpadeine or Nurofen Plus. One, Solpadeine would have paracetamol and codeine, the other one has ibuprofen and codeine. But either one, is the codeine element that causes the problem. But, vast amounts would be consumed, way over the recommended amounts of either the paracetamol or the ibuprofen, which in turn then has health consequences, and they end up in hospital and then sometimes with, one patient I would know of who had a gastrointestinal bleed. That's many of them would have that, but some would die from that. So, that's maybe where I think that's worth flagging. But in terms of the actual statistics, maybe Anne-Marie would speak more to they come in under the opioid deaths. The second question then was about trauma, and yeah, I think that's a very interesting question. Thank you. Yes, we do use our, GPs and others would use antidepressant medication sometimes to manage or help somebody manage traumatic experiences, their background. And then we also know that a lot of drug users would use self-medicate to try and manage their trauma. So, my approach is always psychological supports. And I think, again, I think they're in short enough supply. If you go back to my point where I would be dealing with doctors, dentists and pharmacists, say, for example, who have the same problems and who would suffer trauma, but may have had various traumas in their background, they have resources to access psychological support, and they will use those psychological supports. But there's a whole other cohort of society that we really need to resource better and build in those psychological supports in a range of different forms. There is no, one form of it that will suit everybody, but I think we don't have enough of those, and we need to enhance those really, really strongly, because the cohort we're talking about is, as in substance users, trauma is so important as a part of the reason why they're using drugs.
Okay, I know Jerry and Sean wants to go back in. Can just briefly, Anne-Marie, do you want to make any other comment just on that measurement criteria?
Yes, just on the codeine. So opioids are the second most common problem that we see in Ireland in terms of treatment. About 8 out of every 10 cases that enter treatment for opioid use is for heroin. So that means there's about 2 in every 10 that aren't heroin, and it's another type of an opioid. We do see codeine in our figures. There has been fluctuations over the last number of years. I don't have the exact numbers to hand, but we do see those cases in treatment.
No, that's good and that's clear. Jerry, first of all, and I know Sean wants to come back in briefly.
Thanks, I'll be brief. The biopsychosocial model has been embedded in the addiction services in Ireland for some time, both assessment and then in care planning. Biological can refer to physical damage as well as the kind of medication need, such as injection damage or maybe damage due to nitrous oxide, etc. So there's that aspect, but the psychosocial piece looks at their psychological care and the context of what social supports can be put there. The addiction services also more recently have embraced the idea of trauma-informed care. So, medication is not required for everyone, but certainly we do take on board these more comprehensive aspects, just to say that.
Thank you. Sean?
Yeah, just to come back to the trauma piece, just echoing what Ida was saying, is that like a lot of times people will use illicit substances to manage the trauma that they've experienced. And interestingly, if you look at it on the ground, what that can often do in mental health services is, because of your drug use, it can stop you actually accessing a mental health service. So I just want to say that. So it's not just necessarily about doctors prescribing medication, which is in lots of cases completely appropriate, absolutely completely appropriate. But as Ida was kind of saying, and just to echo that, a lot of people would use illicit substances to manage what's going on. And what we need to do is embrace and work with these people and not try and exclude them from the very services that got set up to work with them.
Okay, I'm going to go back to the floor. Thanks again, panel. So tables 2, 7 and 12, if we can pose 3 questions, please.
Hi, my question is to Dr. Carey. We learned through your presentation that majority of people below 20 years old, they are using cannabis above cocaine. Do we monitor the percentage of cannabis users who transition to regular cocaine users? So that would be the first question. The second would be, do we monitor the cases that have been successfully treated? And my last question is to Dr. Delargy.
I hear.
Is a training for substance misuse mandatory for all GPs?
Okay, very good.
Thank you.
And we will come back to that in a second. So again, we're at table 7.
Hi, I have a question for Dr. Delargy. Just wondering, when a case is presented, because as you say, GPs are the first line in primary care, so when a case is presented, how clear and defined are the pathways to further drug treatment services, in your opinion? Also, is there a consistent approach across GPs? And also, what are the average wait times, and do you feel they're reasonable wait times? Thank you.
Thank you. Very good questions. We'll come back to that now. And table 12, please.
Chair, that was basically our question on the GPs, but in rural Ireland, you mightn't have the need for an addiction service, but we do have GPs, they're in place, but their willingness and availability to get to them can be hard enough for the common cold, and is it possible like that they are going to fill that gap?
Very good, relevant question for rural areas. I'm going to open this out to panel now. I think Anne-Marie first on the cannabis use and migration to cocaine, and then there's a few questions for Ida, just which I'm sure you captured, Ida, I can summarise. Anne-Marie first.
So just for the question on transitioning, we don't capture that data. We currently don't capture transition rates, and it's not something that we do. However, I suppose if there's a recommendation that could come from the Assembly which would be really useful, it's in terms of the implementation of the individual health identifier across the addiction services. If you've heard of the individual health identifier, it's the equivalent of a PPS number for health. So at the moment, what we have data on is cases. We can't see, that if a person's entering treatment in a number of different services, like we've heard earlier today, we can't currently join up all the pieces of that jigsaw and see, well, what are the totality of the needs at a person level. So I think that would be really useful to have that. It would really strengthen the data, and it would strengthen the evidence, for making decisions about planning and about policy. I think the second question was about outcomes. We do currently record data on treatment outcomes, but they're immediate treatment outcomes. They're not included in what I presented today, but we do look at when a person leaves, why did they leave? Did they complete treatment? Were they transferred elsewhere? Did they drop out, or did something else happen? We have data on the different interventions that were provided, how long someone stayed in treatment, if family members or others were involved, and when they left, had things like their alcohol use or their drug use increased or decreased, and so on. So there is that data there, and it is available for analysis.
Yeah, and just to say the full report is on the members' site. So Ida, thanks Anne-Marie. Ida, a few questions around GPs, I suppose pathways, training, consistency, availability, rural areas. Over to yourself.
Yeah. Thank you. I think the first question was, is GP or is substance misuse training, addiction training mandatory? It's not. It's optional, and I think we have a hard job to try and sell it. If you want to say, look, we know this evidence would say that about 45% of all GP consultations have a substance use component to it. So the harms I've mentioned or whatever, and it's really just trying to get that, recognised and get more people interested and involved. As I said, we have embedded it into the GP training programmes now, so the undergraduates or the trainees coming through will do the training programme. And then one huge gap is undergraduate training for medics. There is almost no training in addiction, almost none. And it's very much the Cinderella topic, I suppose, in that regard. So I think there's a lot of work to be done there. The other question was about pathways, and I do think I think that varies really, to be perfectly honest, from area to area. Some support services are more robust and resourced and have good personnel. Not that there's bad personnel, but it's just the numbers aren't there. And in those areas, I think the training, the referral pathways are clearer. But again, I think there's a lot of work that we could do to enhance that and make it very clear, because it is the GP that often is the first person who will see or the problem will be reported to. And just referring back to the codeine is a hidden problem. They don't really present to treatment services as an addiction treatment service, but they will present to their GP, and they will present in because of the health harms associated, and that's often where that problem comes to light. So definitely more work to be done there. The rural GP, again, I suppose it feeds into some of those other things that I've mentioned, is, stigma maybe associated with managing drug users or substance users. They can be problematic. They can be problematic in a GP surgery, and how do we convince, I suppose, our colleagues that actually, because I've been doing this in my own practice with an all-female practice for, as I said, the guts of 30 years, we don't have trouble. We don't have security on the door, to be honest. It's doable, but maybe we've been not strong enough in getting that message out there. I don't know whether that is helpful in terms of your question.
Okay. Thanks. Sean, I know you want to remain briefly, and then we'll go back for the last three.
Just very quickly, just about the rural drug use. So there are the drug task forces that are dotted around the country, and there are actually a lot of drug services that are available in rural areas. So I live and work in Mayo, and there is a drug service there. I think one of the things, just to echo what happened earlier on this morning in one of your sessions, where people were talking about maybe having one phone number that people would kind of get in contact with. That's not a bad idea at all, but what I found when I was working in a rural area was that we had to continually make people aware of the service. And I worked in the job for 11 years, and after 7 years people would say, I never heard of your service. I never heard of your service. And they would say this to me while they were standing up, and behind them would be a poster for our service. So I'm not being facetious, that actually did happen to me. So just to kind of say that I think it's a continual thing that we need to follow through,
Yeah, I think that was well addressed today as well, that issue of just... Okay, so can I go 3 more, please? Table 3, 8 and 13.
Hi, my question is for Dr. Sean Foy. The biopsychosocial model, all 3 areas seem to need to be addressed to treat addiction successfully. Is this actually possible, and what additional resources would you recommend to fulfill this?
Okay, we'll come back to that. Table 8, please.
Again, this is directed at all the panel. You mentioned the requirement to bring in significant training into the programme. If you ask the Assembly for their assistance in getting this through, what are the key areas and who needs that training? Is it clinicians, service providers, general public through education, and all the other service users, the drug users themselves? Who is it that you want that training pointed at?
Can I just try narrow that question in a bit, or home it in a bit? Training is quite broad. Is there a particular area you were discussing at your table?
No, just it came up in the broad context of everyone's
training in terms of addiction services.
Yes. So it's training. Who gets that training? Where are they talking about? Like, are we talking about their own resource, like in Dr. DeLonghi's case, GPs, or are we talking broadly about society getting more training, or is it the service providers? Who needs the training to bring this, to give us a better service and to give the users a better service?
Okay, thank you. Table 13.
Hi, this is a question for Dr. Sean Foy. Did any of your research came across of alternative medicine, like for addiction of heroin, for instance, like ibogaine? They use it on medical centers in the Netherlands.
Okay, we'll come back to that. So, Sean, a couple of questions just around the model itself, success rates and generally resourcing required. I'll come back to the training one at the end, alternative medicine as well.
Yeah, so just an answer to that first question about the biopsychosocial model, like it is in place. I think what we need to do is to resource it more. And I think these questions, interestingly, are kind of linked. If we think about training, we probably need to train people in the biopsychosocial model a little bit more. And I think we need to hold people accountable. So if you're going to be working with somebody, have you considered all 3 areas? And has that been done in a meaningful way? Or has that been done in a tick box exercise? So if you think about the presentation that I gave, one of the things that I was kind of saying is there has to be empathy and compassion. And I've seen a lot of that in my work in addiction. I certainly have seen people that really have a lot of this. But I think in relation to making it more embedded, I think we would need to train more people in it. We would need to resource it more. And also too, I think a broader issue is a cultural shift in our thinking in relation to addiction. Because exactly as Ida has kind of said, like a lot of times people won't necessarily access services because of the stigma that's associated with it. So it's a lot of work. It's a lot of work, but I mean, ultimately, it is in place. I think if we resource it more, we'll probably be able to break down some of the stigma. But I think we actually need to hold people to account. Are you actually doing the biopsychosocial model? So, that's it.
Thank you. Can I kind of use the chairman's prerogative and just in relation to the question of training, just what might be helpful for all the assembly members as well is just from all of your perspectives and on all that you do and the experience you have in relation to drug use. I mean, what in particular do you think we should be thinking as an assembly that will make things better? Is it prevention? Is it awareness? Just, can you give us any insight into, if you were to pick one area that you really feel from broad society perspective, creating a better prevention and awareness, what you might think of? So no order, but Anne-Marie maybe?
I suppose from my perspective, I think, data and evidence can be really useful to try and answer some of these questions. If we look at what I presented today, we see that there are young people that are using drugs at a very young age, so that means we can start to think about, prevention, what needs to be done, what substances they're using, and so on. We also know that we have an ageing opioid population, so, there's more that needs to be done there in terms of making sure that we cater for their health needs. So data and evidence can really kind of support these decisions. To help us to do that, I suppose, would be things like increased coverage, making sure that all the cases that enter treatment are captured in our system, so everyone is counted. And real-time reporting is something that I think could be really useful, both from a training perspective and raising awareness. The idea of having the data there in real time to help you make the decisions and have the evidence at your fingertips is something that could be really, really powerful. A lot of the data does come to us in real time already, so we have the infrastructure to do that, but some of it, there is a time lag, and there are improvements certainly that could be made.
Okay, and briefly go to the other panel as well. Sean, I don't think we addressed the question of alternative medicine. I think that was...
Yeah, I'm probably not the best to answer that, but I mean, the bottom line is I am a scientist practitioner, so if there's an evidence base behind an effective intervention, I'm very keen to use that. So I'm not the best place to talk about ibogaine because I haven't worked with it, but certainly if there's an evidence base behind a particular intervention, I would be very open to kind of using that personally, yeah.
And just briefly, any kind of broad thoughts about it? Just briefly.
Absolutely. So look, get out the perspectives of your local university, look at nurses, social workers, psychologists, and look down the perspectives and see how much is taught in relation to addiction, and you'll find that it's very little. And so I think if we were going to try and change it, if we were actually going to educate people around addiction, try and remove some of the stigma and the shame that's associated with it, and if we were to start now, then I think maybe at some point we might actually kind of turn the ship around a little bit. So,
thank you. Jerry?
Yeah, there are a couple of different strands to this. One is, from the point of view of public information, whenever we become aware of new information or harms associated with drug use, it's important we get it out there so people can become aware of it. So the early warning system becomes very important, particularly if we, as we saw at the festivals where we might get new information. I think for people who are professionals working in the area, discipline-specific training is important so they can use their skills, particularly in relation to trauma and substance misuse and its place in it. I think for young people who I work with a lot, I think the SPHE program in the schools has been progressed quite a bit, but one of the issues that's come up is that teachers are often too busy to be able to get off to get the training, so that there can be practical issues, and we're trying to look at that within the strategic implementation groups in the drug and alcohol strategy. I'm part of the group that's looking at prevention and reducing the harm for young people, so that's one of the core issues for us. And just in relation to ibogaine, we did look at it a few years ago. The evidence base was not as strong as the medications we were using, so that we could see, and so we didn't see any reason to use it, but certainly we had looked at it, and so that was our experience at the time.
Thank you, Jerry. Ida?
I suppose the main message I would say is we need better public health messaging. I think the mental health campaign has actually been working well, and that messaging that it's good to talk and it's okay to talk and come forward to talk. I think we need to get that message out as for substance misuse as well, and try and reduce the stigma that's associated with that. So I'd like to sort of I'd like to see public health getting in behind this campaign, or, you know, better messaging, I suppose, as well as all I concur with what my co-speakers have mentioned already.
Thank you very much. And can I just say, I think it was Sean, I can't remember, one of the panellists said they were privileged to be able to present to this process, and I think we are privileged for people that, of this experience, to come in and present to us and share the information and knowledge and insights. So thanks very much to all of you.